Acute Myeloid Leukemia.
Hi, welcome to the discussion on leukemias. Let's discuss the case of a 65-year-old man with complaints of recurrent nosebleeds and bleeding gums for 15 days. On examination, he had pallor, fever, multiple ecchymotic patches on his skin, and gum hypertrophy. There was no organomegaly. Blood work showed a hemoglobin of 8 gram %, WBC count of 68,000 per cubic millimeter with 68% blasts, platelet count of 15,000 per cubic meter. Peripheral smear showed numerous large blasts with abundant cytoplasm, fine eosinophilic granules, and rod-like structures. Their nuclei had delicate chromatin with multiple prominent nucleoli. Since the blast percentage was above 20%, a diagnosis of acute leukemia was made. The bone marrow showed nearly complete replacement by the same type of blasts which were positive for a special stain called myeloperoxidase (MPO) and for an immunohistochemical marker CD33. These special tests are done to confirm a myeloid lineage. The final diagnosis was acute myeloid leukemia. So what is leukemia? Referring a little blast from the past, leukemia is derived from the Greek word leukos, which means white, and haima, which means blood. It basically describes a condition where abnormal white blood cells replace the marrow and peripheral blood elements. A cutoff of more than 20% blasts in the peripheral smear or marrow is the criteria for diagnosis. Leukemia can be divided based on manner of presentation, acute or chronic, or by the type of blast, myeloid or lymphoid. Accordingly, the classification goes like this: acute myeloid leukemia, chronic myeloid leukemia, acute lymphoblastic leukemia, chronic lymphocytic leukemia. This video is all about acute myeloid leukemia or AML. It is a malignancy of the hematopoietic stem cell which forms blasts of the myeloid lineage. It more commonly affects the elderly. Two classification systems helps us understand this disease better. The first being the FAB system, French American British Cooperative Group Classification, which is based on morphology. And second, the WHO, World Health Organization Classification, which is based on genetics, cellular lineage, and maturation. Feel free to take a snapshot. As the marrow is taken over by the blasts, symptoms related to cytopenias result: anemia, infections due to neutropenia, and bleeding tendencies like petechiae and ecchymosis due to thrombocytopenia, which explains the recurrent nosebleeds, bleeding gums, and ecchymosis the patient presented with. So what are all the tests to be done to confirm this condition? CBC usually reflects the cytopenias with the presence of blasts. A peripheral smear and bone marrow studies give a good view of the blast morphology. Myeloblasts are large abnormal cells with abundant cytoplasm, fine eosinophilic granules which align themselves into rod-like structures called Auer rods. Sometimes these multiple rods can be seen together like a bundle of sticks, hence the name faggot cells. Their nuclei have delicate chromatin with multiple prominent nucleoli. Bone marrow aspiration and biopsy are done for confirmation, where the same kind of blasts are seen sometimes almost replacing the marrow. It is important to differentiate between a myeloblast and lymphoblast. Based on morphology, a myeloblast is larger than a lymphoblast, with more cytoplasm containing eosinophilic granules. Some may show Auer rods. The nucleus has fine chromatin and prominent nucleoli. A lymphoblast is smaller than a myeloblast, with scant cytoplasm, no Auer rods, coarser nuclear chromatin, and inconspicuous nucleoli. Feel free to take a snapshot. Based on enzyme cytochemistry, MPO, myeloperoxidase, and PAS, periodic acid Schiff, stains are very helpful. A myeloblast shows granular cytoplasmic positivity for MPO and is negative for PAS. A lymphoblast shows block cytoplasmic positivity with PAS and is negative for MPO. An easy way to remember, lymphoblasts take a pass at the MPO. Immunohistochemical markers confirm the lineage. For example, in the present case discussion, CD33 was the myeloid marker which confirmed the diagnosis. There are a few types of AML which are unique in presentation and prognosis and are definitely worth a mention. AML M3 is due to translocation, which results in the fusion of RARA gene and PML gene. This chimeric gene prevents the differentiation of cells at the promyelocytic stage. The result? The blood is filled with promyelocytes and blasts, hence the name Acute Myeloid Leukemia. The procoagulant factors released from these cells can trigger a fatal condition called disseminated intravascular coagulation, where clotting factors are completely exhausted from extensive coagulation throughout the body, leading to profuse bleeding. Although a nightmare both for the patient and clinician, the silver lining is that this mutation can be specifically targeted by a drug called ATRA, all-trans-retinoic acid. It pushes the promyelocytes to mature into neutrophils. Once these neutrophils have completed their lifespan, they die. Hence, ATRA treatment rapidly takes out the neoplastic blasts, saving the patient's life. A literal blast-off. Causes of AML M4 and M5 are known for dermal and mucosal infiltration of blasts, leading to leukemia, cutis, and gum hypertrophy respectively. Rarely an isolated collection of blasts may be seen in extramedullary bones, skin, or lymph nodes, forming tumor masses known as myeloid sarcoma. Also called chloroma, the tumor is green in color, rendered by abundant myeloperoxidase content. Click on the link below to know about oral manifestations of leukemia. Prognosis depends on the type of AML and associated genetic alterations. AML associated with translocation 821 and inversion 16 have better prognosis than AML with TP53 mutations. Treatment includes chemotherapy for remission induction, followed by consolidation phase. Hematopoietic stem cell transplant is curative. ATRA is the superhero to the rescue of AML M3. Each lineage of hematopoietic cells has a specific marker for it. For example, the markers for myeloid cells are CD33, CD13, and B lymphoid cells are CD19 and CD22. Immunohistochemistry on bone marrow biopsies and flow cytometry on peripheral blood or marrow aspirants are tests which use these lineage markers to diagnose leukemias.
Pop quiz.
A summary of the differences between ALL and AML are as you see on your screen. Feel free to take a snapshot. Hope you had a blast learning with us.
Think out of the box. Explore more such videos on our website.